It's a pleasure to virtually meet you all. I'm Ronnie Grosfeld, in charge of Latin America and the Iberian Peninsula regions on behalf of Medispec, of course. And I would like to welcome, first of all, our guests from Asia, Europe, Africa, the Latin American region, and the Middle Eastern region. And between parentheses, a special welcome to Dr. Ahmed El-Demerdash, that I saw on the list of participants, and I've known him for the last 25 years, so I'm really excited to see him again here. I would also like to welcome Medispec sales, marketing, services teams, and our management. And most importantly, I have both the honor and the pleasure to introduce to you with a warm welcome our guest speaker, urologist, expert in sexual medicine, Dr. Professor Arai Vela Mosquera from Ecuador. She's a professor at the urology faculty of the... I hear echo. I'm sorry. Okay, so about Professor Arai Vela Mosquera. She's a professor at the urology faculty of the prestigious International University of Ecuador, a specialist in human talent in health, who created a continuous educational program called Sexual Medicine for Life that is taught to health professionals and patients. She's also a member of the Ecuadorian Society of Urology, a member of the American Confederation of Urology, a member of the Latin American Society of Sexual Medicine, and a member of the International Society for Sexual Medicine. So once again, welcome to everyone. And today's webinar topic is how to correctly select patients for an erectile dysfunction shockwave treatment. The treatment discussed today is twofold. First, the principles and current state of the application of low-intensity shockwave for erectile dysfunction, and the methodology for selecting the correct patients using Medispec's ED1000, which is based on our multi-wave technology. That technology is proprietary to Medispec and is unique because it has multiple points of reflection, which allows a deep and wide treatment area with an ideal power level, yet without pain to the patient. So today's webinar is particularly interesting since it provides hands-on experience as to what seems to be the optimal methodology for selecting and treating ED patients for obtaining the highest clinical results. Before we start, some formalities. Please type your questions in English in the chat box section. Towards the end of the webinar, we will allocate time for Q&A. The session is recorded and will be shared along with the presentation shortly after the webinar. During the webinar, everyone will be muted to avoid background noise. And I invite you to stay tuned by regularly following our social media posts, as we will announce our next event very soon. And now I'm handing over the microphone, or the virtual microphone, to Professor Arai Vela. Thank you very much.
Good morning to everyone, and thank you, Ronnie, for your words. Thank you all for your invitation. Thank you for believing. We'd like to give eternity to our loved ones, but death always happens before one can expect it. But what if we could find the secret of eternal life? Dracula is a Bram Stoker's literary myth based on Countess Elizabeth Bathory, a 16th century serial killer. She drank blood of about 650 women just to eternally preserve her beauty and youth. Count Dracula said, "Blood is life," and he was right. Endothelium is like the yin and the yang. Inside it, there are life and death. Everything goes well as long as endothelium is healthy. It regulates several functions, preserving cellular breathing. That's why we maintain our beauty and youth. When it is dysfunctional, it turns against its owner and vasoconstriction happens, then intima media thickness increases, and finally atheroma formation occurs. So we age, we wrinkle, and realize we have been dying. Development of new blood vessels occurs in two instances. The first one during embryonic period known as vasculogenesis. That is the initial creation of the circulatory system. Later on comes angiogenesis, the development of new vessels from pre-existing ones. Erectile dysfunction occurs because of a blood leak, when inlet pressure is less than outlet pressure. Veno-occlusive dysfunction is divided into primary and secondary. Primary ED appears in youth and it is diagnosed around 26 years of age. Its main cause is deep dorsal vein disease. Secondary or late ED may present as an endothelial dysfunction or a structural dysfunction. Endothelial dysfunction's origin is often metabolic. It can become a structural dysfunction. Ischemia can progress and lead to fibrosis of the muscular and the endothelial tissue. For example, in hypogonadism, fat replaces cavernous tissue and smooth muscle. Fibrosis or apoptosis also occur. Inflammatory factors such as TGF-beta1 are involved. On the other hand, traumatic fibrosis may occur in the albuginia, as in Peyronie's disease, or from chronic cavernal trauma, as in traumatic cavernosopathy. Ischemia is worse than it seems. Padua and MacLean suggested that an hypertonic pelvic floor may initiate and perpetuate urinary symptoms, sexual symptoms, perineal pain symptoms, and gastrointestinal symptoms. The alpha-1 hypertonia is associated with ischemia and other chronic inflammatory factors such as TGF-beta1 and other endothelial growth factors and some interleukins. For centuries, the human being has searched for the formula of eternal life, from alchemical elixirs to cryopreservation, tissue generation, the use of stem cells, cloning, and transplantation. Doesn't shock waves have the principle of eternization in their essence? The shockwave therapy was born in 1970 with stone fragmentation, then orthopedic disorders and wound healing. 20 years ago, it was used in cardiology, angiogenesis. For the first time, 10 years ago, Medispec promoted the first studies on erectile dysfunction with Dr. Vardy. He applied low-intensity shockwave therapy in 29 non-responders to PD-5 inhibitors with a 72% success rate. Currently, low-intensity shockwave is applied with success in gynecological and kidney diseases. There are several ED treating devices with different types of energy: electrohydraulic, electromagnetic, and piezoelectric. There are important differences regarding the wave penetration and the intensity of focal energy. It is most likely that the electrohydraulic technology is the one with most studies and scientific evidence. But how do we get a shockwave? The electrical energy generates an acoustic impulse from where a pressure wave occurs originating a shock wave that penetrates deeply and causes a biological effect. A true shock wave is focused and faster than the speed of sound. Pressure's rise time is fast, and it is followed by a low tensile phase with great penetration. A new proverb says, "A butterfly flaps its wings in Ecuador," and subsequently a storm thrills Europe, Asia, and the rest of America. The butterfly effect explains that a sequence of interrelated facts in a chaotic environment produce unpredictable consequences. The human body is a chaotic system, so the cause-effect determinism is impossible. Miracles exist in medicine, but chaos is not disorder. Etymologically, it means a whole. According to chaos theory, tiny things cause enormous changes. Then chaos is genesis. The wave effect has its own chaos. Low pressure phase results in the formation of microbubbles called cavitation bubbles. These cause microtrauma, activating repair mechanisms with transmembrane protein signaling, upregulation of vascular growth factor, and nitric oxide synthase, both endothelial and neuronal. Endothelial cells are involved, also those of immune system, fibroblasts, nervous, and stem cells. Somebody is speaking. Joanne. Okay. Through a process of destruction and construction, the low-intensity shock wave generate a considerable effects in the short, medium, and long term on the blood vessels, endothelium, smooth muscle, albuginia, interstitial tissue, and nerves. Although we could suspect cellular trend, clinical results are unpredictable. Nitric oxide is released immediately. 25% of my patients said they felt improvement on nocturnal erections after the second sessions of low-intensity shockwave therapy. None of them were diabetic. Okay. Are you listening to me, Ronnie? Are you listening? Okay. Stem cell chemoattractant activates circulating endothelial progenitors, which contribute to angiogenic process and repair damaged erectile tissue. Low-intensity shockwave resulted in reduction in TGF-beta1 and improved collagen production, allowing the fibroblasts to restore elasticity and expandability of the erectile tissue, as well as diminish obesity-related pathological changes. It also improves blood flow and reduces cavernous fibrosis. Radical prostatectomy produces neuropraxia associated with the rise of the pro-inflammatory factors and the decrease of antifibrotic factors. Another mechanism for post-operative dysfunction could be the cross-section of accessory pudendal arteries, that leads to penis fibrosis regardless of nerve injury. Penis fibrosis results in a structural venous leak in about 35% of patients. Bacaglini's study showed no significant improvement in the IIEF, but Peter Bill's study showed improvement in both IIEF and erectile hardness score with statistical significance. Low-intensity shockwave seems to increase expression of alpha-2 adrenergic receptors and simultaneously decrease expression of alpha-1 adrenergic receptor. This possible decrease in sympathetic activity may lead to easier smooth muscle relaxation, may be a good option for those with performance anxiety and pelvic floor hypertonia. Treatment with low-intensity shockwave seems to be a philosophical problem. Preclinical studies are clear in their results, while clinical studies are confusing. Yet, let's not forget, we don't work with rats. We are treating men. And lastly, scammers should also be considered in this path. This complete Sokolakis review included 15 experimental studies related to ED and 44 experimental studies in the field of orthopedic, neurological, and cardiac diseases, as well as wound healing processes. There is little information of the number of shocks, the energy flow density, and the total energy applied. However, the results have been evident. Most of these studies were conducted on sick or sicknet rats, sicknet, mimicking ED of vascular origin such as Goto-Kakizaki diabetic rats and obese and hypertensive sucker rats or rats with cavernous nerve injury. Also, normal Sprague-Dawley rats and natural aged Wistar rats. Some studies included in vitro application of low intensity in rat strand cells cultures, endothelial cells of human umbilical vein, and stem cells cultures. Regarding clinical studies, Borst and collaborators selected 11 clinical studies and 5 meta-analyses. There was evidence of improvement in erectile function, but Yamakake reports no effects in Doppler parameters. Also found no difference between patients with low-intensity shockwave therapy and placebo. However, there are studies with objective evidence of improvement in peak systolic velocity. Also, we have 4 clinical studies and meta-analyses evaluated low-intensity shockwave for Peyronie's disease, and 5 clinical studies investigated low-intensity shockwave for chronic pelvic pain syndrome. Results showed a possible effect on pain in both diseases. The results of on effectiveness have always been affected by the small number of patients. Disparity regarding energy applied and a great heterogeneity of used protocols. Regarding Peyronie's disease, Borst reports a small statistical decrease in curvature and plaque size in the low-intensity shockwave therapy group compared to small increase in plaque and curvature in placebo group. In most of the studies, the low-intensity shockwave therapy did not modify evolution of the disease. All trials showed pain relief. The fact that there are several protocols is not bad. It is logical. There are different expressions of the disease even in the same stage and at the same time of evolution. Chronic pelvic pain was relieved in patients who received low-intensity shockwave therapy in controlled placebo studies. There is a possible reduction of tone and spasticity of the pelvic floor. Professor Ilan Grunwald presented this year a prospective double-blind randomized and placebo-controlled study in women with vulvodynia. The response was measured with an algometer and validated scales. There was a pain reduction and increased tolerance only in patients with low-intensity shockwave therapy. It's likely that the release of anti-inflammatory factors, angiogenesis, and pelvic floor tone reduction are responsible for the relief. There are new protocols being tested for vaginal dryness and orgasmal dysfunction. With this experience, Dr. Lim recommends the application of low-intensity shockwave in women's chronic pelvic pain, and I am starting. Despite evidence and multiple studies, low-intensity shockwave is still considered an unauthorized and not recommended treatment. But treating men is different. Men are afraid. Each has his own story and experience. Spontaneity is the ability to change without an external stimulus. It seems that spontaneity gives freedom, but it has the burden of human feelings. I think this is one of the biggest problems in clinical studies. Indeed, this patient is naked, depending on his own arteries, without a pill, depending on his own sexual and human response. You cannot be spontaneously happy when you take an antidepressant. Preclinical studies have no doubts, but I've never seen a rat with partner problems or unemployment stress or performance anxiety or working night shifts. The failure of heterogeneity is an affirmation that we do not treat penis but human beings. Sexual dysfunction is a symptom of a disease, and the disease has to be remembered all time and treated, even though it is psychogenic. On the other hand, male health is a profit-driven business. It doesn't exist for public health programs. Shockwave devices are part of aesthetic treatments in spas or misused in companies run by scammers who sell treatment also to everyone with no scientific responsibility. It is an expensive treatment, and this causes sometimes fear. It's difficult to tell a patient that he will spend a lot of money and improvement may or may not meet his expectations. Doctors are not wizards. We have not defeated death. We are just guiders in a relief process authorized by the sick. However, correct evaluation can be magic in our hands. European guidelines are ambiguous, and American guidelines consider the low-intensity shockwave therapy still under research despite a recent exponential growth in the use of this therapy in the United States. Recommendations sponsored by the University of Buenos Aires are clear when describing the results. They mention clinical improvement. Also, it comes clear that low-intensity shockwave increases PD5 inhibitors efficiency, but without normalizing erectile function. But Is it normal to have erection even when there is not an ideal circumstance? Failure is also spontaneity. Automaticity is not normal, is not natural. European Society of Sexual Medicine insists that the answer is only based in symptoms, but there is hemodynamic improvement also. So it mentions variable effects up to 12 months, but Dr. Apple and his colleagues presented the results of 60% of patients maintaining improvement up to 25 months. However, there is no recommendation, so more than 20 years of angiogenic evidence have been not enough. In Peyronie's disease, there is pain relief without modification in the curve or the plaque. But could we interfere in the final evolution with the correct timing of the application? Maybe starting earlier. In chronic pelvic pain syndrome, there is pain relief, but it is unknown how long it lasts. You have to discard false negative seminal studies because it doesn't work in chronic prostatitis. During these 5 years with the Medispec ED 1000, I have treated 97 patients with an 85% success rate. Many errors in my way. I have learned to value singularity, to inform, and to correlate clinical findings with ultrasound results. It is clear that men are not always honest in their responses. 1/3 of my treated patients showed improvement in their Doppler parameters, but had no clinical response. The penis may be healthy, yet the patient may still have no erections. With this experience, I have designed an evaluation chart with parameters which I have noticed affect the diagnosis and the evolution. I base my evaluation on 3 pillars: selection, information, and validation. And after a clinical exam, I indicate a metabolic assessment and diagnostic penis Doppler ultrasound. Nocturnal erections are important, are evidence of better health, even though its absence is not necessarily real. They may occur and the patient is sleeping. Duration of ED is important. Patients with more than 2 years of stable ED have worse outcomes. They may report penis shrinking. Pelvic injury, uncompensated metabolic comorbidities, vascular or structural diseases, fibrosis, cavernous calcifications also worsen prognosis. I prescribed tadalafil 1 month before low-intensity shockwave therapy. Alterations in cavernous artery, intima media thickness diagnosed systemic atheromatosis with sensitivity and specificity close to 90%. I consider Doppler a prognosis exam and intima media thickness as diagnostic support. Treatment will be validated with post-therapy Doppler ultrasound. I recommend choosing a customized dose of intracavernous injection for both pre- and post-treatment ultrasound. We use Trimix. It's easy to decide when patient reaches my 6 points it is mild clinical and echographic ED. I give 6 sessions with 1,500 shocks in each, daily or on alternate days. Compensated means a difference greater than 10 centimeters per second between the left and the right peak systolic velocity, but with adequate erectile response in Doppler ultrasound. It is also easy to say no. I do not treat clinical erectile dysfunction without ultrasound evidence or patients with shrunk penis. Neither those who have no response to intracavernous vasoactives or those with bad results in the Doppler ultrasound. My decision is always personalized. We must remember that decompensed metabolic diseases affect the final evolution. Conditionals are the classic non-responders. Here, I evaluate data not included as age, another medication or stress, partnership, smoking, psychiatric background, and sedentarism. A conditional yes may not be treated, and vice versa. Erectile dysfunction is a vascular and a metabolic disease. We must remember at all times that we are not treating penis. A satisfactory erection cannot be the only goal. That's why we fail. So low-intensity shockwave therapy is ready for clinical practice. Are we? Why should we compare between these two? I'm always looking this comparison, absurd comparison. The low-intensity shockwave therapy is a different alternative and cannot be compared to a pill. See how easy it is. The FDA approved a vaccine in an experimental phase without established protocols. Is the fear of dying more important than the need to live better? Without quality of life, eternity is useless. And here we reach the end. The wave effect increases nitric oxide production, undeniable. It also eases neoangiogenesis and neurogenesis, undeniable. Clinical studies have controversial results, but determinism in clinical practice is not feasible. Low-intensity shockwave therapy is not a pill. It is another therapeutic option that brings spontaneity and depends on singularity. ED is a multifactorial disease, and it must be diagnosed and treated in the same way. Before questioning therapy, we must protocolize evaluation. Someone said, blood is soul. The scientific world continues to investigate the result of the low-intensity shockwave. But what about the first step, the pre-treatment evaluation? Why spend time questioning the undeniable, the wave effects, and the chaos of singularity? And thus, it will be easier to become Dracula and drink blood to eternalize our existence. This is all I have for you. Thank you very much.
Thank you very much, Professor Arai Vela. It was a fantastic presentation. Muchísimas gracias. We are now opening the questions and answer session. So feel free to write your question in the chat, and we'll be delighted to transmit it to Dr. Arai. So I'm reading here a question. Hi, you mentioned that you are starting to treat women. Are we able to use the ED1000 system for the women treatments as well?
Yes, I'm starting my experience with women, but what I have read is great. There are good options and hope for women that cannot have a hormonal treatment for their vaginal dryness. So I'm doing it. I'm starting. Maybe in 1 year we can meet and talk about women.
Okay, there's another comment here that says, thank you, Dr. Vela, for this important and innovative information. I would appreciate receiving more information on the use of waves in vaginal problems, vulvodynia, infections, dryness. So we are taking note of this, and we should follow up on this. It's more a comment than a question. There's another one here. Thanks for the great presentation. Can we find a copy of the PowerPoint slides somewhere? Yes, at the end of this webinar, we shall be broadcasting both the presentation and the recording. So you'll have the pleasure to read and enjoy Dr. Arai's presentation over and over again for eternal life. A question here in Spanish. Excelente presentación. He remitido mis pacientes post-prostatectomía radical y han respondido satisfactoriamente. Actualmente estamos iniciando con prostatitis crónicas y prostatodinias. Would you like to comment on this?
Yes, it's great to work with the ones who received this surgery, enormous surgery, radical prostatectomy, and it's important to start earlier because patients come 2 or 3 or 10 years later. And that's why we don't have any response.
Perfect, thank you. I'm reading more comments and questions. Wonderful, Dr. Arai. Vela is one of the wiser urologists I know. We are so proud of her here in Ecuador. Thank you for this fantastic presentation. We are also very proud of you here at Medispec. So I can only reinforce this message. Another question, what is the mechanism of action in addressing CPPS? Thanks.
Relaxation is the secret. Relaxation, the hypertonia is diminished when you bring new blood to the pelvic floor.
Thank you. Another comment here, muy buena conferencia, very good conference. A question, how does low intensity shockwave therapy treat vascular leak? Thank you for a very informative lecture.
Thank you. When you increase inlet pressure, you increase new vessels, then the pressure is higher and you can push the outlet pressure. You can diminish your outlet pressure. It's trying to return to original erection, adolescent erection.
Thank you. Dr. Arai, may I suggest that you turn off the sharing screen so that we can see you in Zoom in full screen? Yeah, perfect. Thank you. Another question, where or which, no, I'm sorry, one more before. Do you test, well, congrats, Dr. Vela. Do you test testosterone previous to LIST?
Always, always. When a patient has a problem with erectile dysfunction, when any problem with sexual dysfunction, you have to test testosterone.
Perfect, thank you. Next
Metabolic, sorry, Ronnie, but you have to remember, and Dr. Rivero is fighting always with this. The penis is not just it, is a man behind the penis. So you have to treat the man behind the penis.
In my case, these are two separate entities. Okay, next question. Where or which platform will you be broadcasting the PowerPoint presentation? It will be sent by email to all those who to all those who registered to this webinar. So it will be sent. And Dr. Forti, in case you don't get it, I will send it to you personally. A comment from Spain. Enhorabuena por la presentación, muy buena. Very good presentation.
Gracias. Thank you.
Another comment, excellent conference. Thank you very much. And I think that with this,
Ronnie, can I ask a question from here?
Yes, please.
Dr. Arai Vela, so we are all excited and thank you again for the lovely presentation. You mentioned the COVID-19 vaccine. We are wondering whether during this period, did you see a rise in demand of people asking for a solution for erectile dysfunction compared with the time before the pandemic?
Yes, it's like a mixture of problems. You have economic problems, so people wants to take the treatment, but they don't have money. But I am looking something strange. People that is getting the vaccine is also showing problems with their sexual function. Then it is very important to speak with men in this right moment. But yes, people is in need, but with lots of economic problems. No money.
Thank you. Our next product will be a money printing machine.
Great.
Okay, I have a comment here in Spanish. Lo he utilizado en pacientes con disfunción eréctil que ya no responden a inhibidores de PDE5 con buen resultado. I've already used it on patients with erectile dysfunction that are not responding to PDE5 inhibitors with good result.
Yes, those are my conditional patients. You have to choose correctly, because if you have this patient that maybe is a good candidate, he's going to be a good responder to low intensity shockwave therapy, but he has a bad wife, he's obese, he has a decompensated diabetes. You have to stop the indication and talk with this patient and solve his problems first, and then give the low intensity shockwave therapy. Conditionals are very difficult to treat. Is maybe the group that demands more attention. Professor Lim, I love you.
Yes, I love you too. You're such a good researcher. I actually want to make a suggestion to you. During this COVID, I had a patient who received the vaccination, and a few days later, he developed acute erectile dysfunction. Right. So I would propose you should investigate this type of patients, and if you can gather enough. I only had one patient in this whole 1 year, so I cannot make strong statements about it. But I've read from my colleagues that the vaccination has produced some victims with erectile dysfunction, and I actually saw one patient exactly happen that way. So it would be a good research project to do this if you have a lot of COVID patients or people going for vaccine in your country.
Yes, yes, Professor, of course. It will be an honor for me. I will do it. I have 3 patients and I have prostatitis, viral orchitis. So it's incredible what I've been seeing with the vaccine.
Which vaccine was it? Just to...
I won't say it here. But you know, Ronnie, I told you.
Okay, I just wanted to educate the audience. Okay. Right, if there are no further questions, I would like to summarize this session. So first of all, thank you very much, Dr. Arai, for accepting our invitation. Thank you very much for the entire audience for taking the time to listen to us, to listen to Dr. Arai and to our experience. The conclusion is that with the right selection methodology, before, during, and after, there are means to reach quite high results using the ED1000. So you mentioned 85% of success rate. It's a relatively high success level, and we can attribute it to your methodology, I believe. So any one of the audience that uses the ED1000 and wants to contribute his knowledge and experience is more than welcome to contact our marketing department, and would be delighted to organize another webinar, maybe on a specific topic that can interest other doctors, other users. So once again, thank you very much. Muchísimas gracias. Shukran. Merci beaucoup. I don't know what other language to use.
Thank you. Thank you very much. Thank you, Professor Lim. Hugs to all. Thank you.
Thank you too, and bye.
Thank you.
Thank you.